Hi everyone, welcome to a brand new topic now looking at respiratory disorders. And in this recording, I'm going to be reviewing some common terms and talking about various different lung conditions. Let's have a look at the normal anatomy of the respiratory tract, reminding you of a few things. We can separate our respiratory tract into our upper and lower respiratory tract. The upper respiratory tract really ends at the first part here of the trachea. And we have respiratory passages through our nose and through our mouth. Then here is our throat where air will pass through. Our larynx, which is the voice box. The trachea, now that we're getting into our lower respiratory tract, will branch off into a bronchus on either side, which will enter the lungs. And then we have further branches called bronchioles. And then at the very end, we have what are called alveoli, and it's the alveoli that permit gas exchange. And what I mean by that is the oxygen that we breathe in needs to get into our blood in order to then travel to the left side of the heart to be pumped into our systemic circulation. We can also see the veins here that possess deoxygenated blood that will be then oxygenated, but we also will be breathing out carbon dioxide. So this gas exchange occurs for both oxygen and carbon dioxide at the level of the alveoli. Much of our respiratory tract is considered a conducting airway, so air is conducted through these really tubes. And then we get to the point where we enter the respiratory component, where gas exchange will occur, and you can see the alveoli here. In this image, you can see the extensive capillary network in this drawn image, but it's designed to show you how the blood that will enter the lungs to become oxygenated will then return to the heart, to that left side to be pumped out to the systemic circulation. When someone has a disorder of the respiratory tract, it can affect the upper respiratory tract or the lower respiratory tract. I'm going to elaborate a bit on the alveoli where the gas exchange occurs, and there are different structures that make up the alveoli. And we're going to have a look at what the normal function is and then describe what could happen if those normal structures are not functioning as they should. Type 1 cells, as part of the alveoli, are involved in providing structure to the alveolar sac. And so if you lose the structure because there's some sort of dysfunction in those type 1 cells, then this can affect ventilation. And ventilation is just the movement of air from the outside world into our lungs via inhalation. And then, of course, the opposite would be true for expiration, where we can also breathe out air from our lungs into the environment. Type 2 cells produce surfactant. Surfactant is a substance that helps reduce the surface tension within the alveoli, and without surfactant, the alveoli can actually collapse, and that will make it very difficult to breathe. The interstitial space is the area that's between the alveoli and the capillary bed that really surrounds it. And if there is an increased distance between these two structures, that is the alveoli and the blood vessel, then it's going to make it more difficult to properly permit gas exchange. So we can see the diffusion of oxygen from the alveoli to the red blood cell, and then the diffusion of carbon dioxide through these walls to the alveolus. So we need to make sure that that interstitial space is not too large. Endothelial cells, we know, are the cells that make up our blood vessels, a specialized type of epithelial cells. And if they are not healthy, if there's a problem with their structure, it's going to make it difficult to properly have the oxygen leave the alveoli, perfuse really through that endothelial tissue to reach the red blood cell. And then similarly, can become more difficult for carbon dioxide to leave the blood vessels and enter the alveolus so that we can breathe it out as a gas. Looking at this image here to orient you, what we have is an example of two alveoli, and this is representing the airway. So we know that air that we breathe in would reach the level of the alveolus, and when it does, then the capillaries that surround it are going to allow for gas exchange. And so here we have deoxygenated blood reaching the alveoli, so it will be pumped from the right side of the heart to the lungs. And then when oxygen is breathed in, that oxygen will be taken up by these blood vessels, and now this blood is oxygenated, and it will travel to the left side of the heart. But what we want to happen is good perfusion. So we want to be able to fully ventilate the alveoli. So VA is referring to alveolar ventilation. This is how well does the air that comes in ventilate the alveoli. If for some reason there was a narrowing here, so maybe it was constricted, and we've reduced that lumen size, we're going to not be able to ventilate that alveoli as well as we can in this case. And so ventilation perfusion ratio refers to how well is that alveoli being ventilated with air, and then how well is the vessels that surround it picking up that oxygen. We want good ventilation and good perfusion. Now there could be a situation where there is a narrowing of this airway, which means less air, less ventilation will occur of this specific alveolus. But yet we've still got a good blood supply around it. Now, if we have this blood supply that surrounds this poorly ventilated alveolus, we're not going to be fully oxygenating this blood because not a whole lot made its way through. And so one of the compensation mechanisms that our body will have in an instance such as this is it will cause constriction of this vessel that surrounds this alveolus to allow for blood to be diverted to the better functioning, the better ventilated alveolus. Now I'm going to review some terms that you've heard before. Hypoxia. Hypo is low. Ox is referring to oxygen. So this is low oxygen within the cells, and cells make up tissue. So the tissue itself has not received as much oxygen for its metabolic needs. And why does that happen? Well, there could be ischemia. Maybe there's a reduction in blood flow, so that cell is not getting enough oxygen. Hypoxemia is low oxygen in the blood, and that can be another reason for hypoxia. If there's not as much oxygen available in the blood, emia referring to blood, then the tissues that blood is traveling to are going to end up becoming hypoxic. As a side note, the term anoxic refers to no oxygen at the cell versus just a lower than normal amount. Hyper means more than, and capnia refers to carbon dioxide. So this is very high levels of carbon dioxide within the blood. And this is caused by hypoventilation. Because when a person is not breathing properly, they're not breathing fast enough or at a normal rate, then they can't breathe off that carbon dioxide, and so it builds up in the blood. Opposite to that is hypocapnia, very low levels of carbon dioxide in the blood, and this occurs in states of hyperventilation, breathing much faster than is considered a normal rate of breathing. And the reason it causes hypocapnia is because you're breathing off too much carbon dioxide, and we do need to have some present within the blood. So you know that hypoxemia is a reduced oxygenation of blood, now specifically arterial blood. And it can be caused by respiratory alterations. So we're not getting enough oxygen into our blood, which then can later be utilized by our tissues. Hypoxemia can result from a few different reasons. One is that there can be a reduction in delivery to the alveoli. So either maybe the oxygen availability in the air is less, and that can occur at higher altitudes. Or maybe you're not ventilating the alveoli enough. There can also be issues where there's an alteration between the affinity between hemoglobin and oxygen. So we know that hemoglobin, which is part of red blood cells, is wanting to bind. It has an affinity for oxygen, and oxygen wants to bind to it. But if there is some state that is not favorable for the proper binding between these two, then that would mean that there's a reduction in the amount of oxygen that ends up being carried to tissues in our body. And there can also be an imbalance in that ventilation perfusion ratio that I introduced on an earlier slide. I'm going to start with the imbalance of that ventilation perfusion ratio. So we're going to be looking here. And for a moment, I'm going to go back to that slide we looked at earlier, reminding you that this is normal. So we have normal ventilation of each alveolus and then a normal blood supply throughout, which is going to lead to this from this state of deoxygenated blood returning to the lungs will now be oxygenated, and it will be able to head to the left side of the heart. But there are certain situations where that ventilation perfusion ratio might not be working properly. And we have three states that we're going to look at. One is a state of a low ventilation perfusion ratio. And in this example, we have impaired ventilation of this alveolus. So oxygen or air will get into this one, but it won't get into this one. And because of that, the blood that surrounds it will remain deoxygenated, and that will join in with the blood that's returning to the left side of the heart. But this one, of course, will be oxygenated. So this leads to hypoxemia because we are not fully oxygenating the blood. In this case of a very low ventilation perfusion ratio, what we have is an area where ventilation has been completely blocked. We have a collapsed alveolus, whereas this one's fine. This is also going to lead to a state of hypoxemia because now we're getting really absolutely no oxygen entering the blood that surrounds this alveolus. Whereas this one, you might get a little bit through. With a very high ventilation perfusion ratio, what we see in this example is the ventilation is fine. So we're able to get air into each alveolus. But the problem is actually with the blood vessels. So there's some sort of clot here, let's say, some sort of blockage. And although we can get blood to surround this alveolus to become oxygenated and then travel to the lungs through the pulmonary, or to the heart through the pulmonary veins, this one is just not getting the same blood supply because of that blockage. And so this also leads to a state of hypoxemia because this alveolus is not able, even though it wants to, because it has the oxygen there, it's unable to contribute to oxygenating the blood. So in order for gas exchange or gas diffusion to occur, we need good ventilation to the alveoli and we need good perfusion of the blood that's there. Now I'm going to talk about how there can be altered affinity between hemoglobin and oxygen. And I'm first going to describe to you the normal situation when it comes to affinity, and we're going to reference this graph. Just try and listen for a moment without writing everything down that I say. I just want you to grasp the concept. When hemoglobin molecules, which are part of our red blood cells, bind with oxygen, it's going to form what's called oxyhemoglobin. And the hemoglobin saturation with oxygen, where's it going to occur in the body? Well, it's going to occur at the level of the lungs because that's where we pick up oxygen. And so where would hemoglobin desaturation occur? Well, that's going to occur at the level of the tissues because that's when we want to get rid of the oxygen that's bound to hemoglobin. This graph shows you what it would look like if we were to plot this hemoglobin saturation and desaturation. If we were to plot it, this is what it would look like. And the normal curve here, it takes on a bit of an S-shaped curve, is shown by this black line in the middle. And it's referred to as an oxyhemoglobin dissociation curve. So it's describing again at what point would we see hemoglobin having a high affinity for oxygen and therefore becoming saturated with it versus hemoglobin having a low affinity for oxygen and therefore becoming desaturated or releasing it at the level of the tissue. And so the basic points to make here is that under a normal circumstance, what we can see, I'm just going to grab a pen. This here is showing you partial pressure of oxygen, represented, pressures represented by millimeters mercury, and then this is percentage saturation of hemoglobin. When partial pressure of oxygen is less than 60, and I'm not going to ask you this specific number, is less than 60, then it is going to be unloaded to tissues. And so that means that hemoglobin's affinity for oxygen decreases because we want to unload it. But when above this, this is where hemoglobin is going to be completely saturated with oxygen at the level of the lungs. And this is where the curve becomes relatively flat as we move in this direction. An important point to make here, though, is that even though this black line here curve is representing normal, of course, this is not a normal course, so we're going to look at two states where we can deviate from normal, where we can have an abnormal increased affinity and an abnormal decreased affinity for oxygen to hemoglobin. So what states can cause that? Well, they're highlighted on the slide here for you. If somebody is in a state of alkalosis, that means that they have an increase in their pH. So their blood is more basic, more alkaline. And this will oftentimes also occur, this increased affinity, when there is a reduction in partial pressure of carbon dioxide. So maybe a hypocapnia state. This will cause an increase in affinity. But these states here, which is the opposite, where somebody is acidotic, that means their pH is low, so acidic, and they might have high levels of carbon dioxide, they might be hypercapnia, experiencing hypercapnia. This can cause a decreased affinity of oxygen to hemoglobin. And if we are not able to saturate hemoglobin because of an acidotic state, you can see why tissues would then be not receiving as much oxygen. And so we always want to have higher affinity at the level of the lungs and lower affinity at the level of the tissue where we want to drop it off. But certain conditions can promote what we don't want. What if we look at it in another state where somebody has increased affinity at the level of the tissues? That means we're not going to be able to drop it off so that the tissues can use it. So what we want is hemoglobin to hold on to oxygen at the right time and let it go at the right time. But certain conditions within our body, such as the examples that I gave you, can change or alter the normal affinity. I'm going to summarize some of the common clinical manifestations of respiratory disorders. So we're talking about the signs, the symptoms, the evidence that a respiratory disorder exists. And remembering too the difference between a sign versus a symptom. A sign would be something that you can measure objectively. A symptom is something that's subjective that the patient would describe. So you have to sort of take their word for it when they say that they're experiencing it. And many of these we've talked about already during our cardiovascular disorders lectures because of that overlap between somebody with a cardiovascular system disorder and the impact that it can have in serious situations on the lungs. Dyspnea is breathlessness, shortness of breath, labored breathing. And this is subjective. This is the patient saying that they are having trouble breathing. It feels uncomfortable. They don't feel like they can properly move air. Orthopnea is a form of dyspnea that is positional, and it occurs when lying down. And there is a number of reasons for it. When you're in that horizontal position, it redistributes your body fluids. It causes your abdominal contents to put more pressure on your diaphragm. And remember, the diaphragm is a vital structure for normal breathing. And so it makes the respiratory muscles have to work harder to achieve the same thing. Coughs can be described as dry or productive. A dry cough is an irritating cough that doesn't bring up anything, so it's considered non-productive. Whereas a productive cough, sometimes described as a wet cough, is one where the person will say that they're coughing up saliva and mucus from the respiratory tract. And so that's called sputum. In some cases, somebody can cough up blood, and the appropriate term for that is hemolysis. So that's described here, and that's really considered a severe symptom. Now, if somebody has blood, if you say cough or sniff back through your nasal cavity and then you spit out sputum and you notice there's a little bit of blood, it does not mean that it's coming from your lungs. It could be some irritation throughout your nasal cavity or your throat where a little bit of blood got into that fluid that you spit up. But actual blood coming up from the chest can represent a more serious condition, although not always. Sometimes people cough so hard when they have a condition such as, say, bronchitis, that it can cause a little bit of blood. But in many cases, coughing up of blood, especially in somebody who may have been a chronic smoker throughout their life, is concerning. In terms of pain caused by pulmonary disorders is really originating from the pleura. It can also originate from the airways, and it can originate from the chest wall. There isn't actual receptors in the lung tissue themselves, and that can be a problem if somebody has lung cancer because it can grow without them noticing it because they're not experiencing pain. And only when the pleura is affected, that's the coverings of the lungs, or when the airway itself is affected, or the chest wall, if a tumor grows into it, only then will a person experience pain if those structures are irritated. Now we'll talk about clinical manifestations of respiratory disorders in terms of respiratory rhythm changes. We've already looked at hypo and hyperventilation. Hypo referring to lower than normal rates of ventilation, and this can cause hypercapnia. Again, that's because you're not able to breathe out enough carbon dioxide, so it builds up in the blood. And this can lead to respiratory acidosis, where the levels of carbon dioxide are too high, and there's an association there with acidity. Hyperventilation, higher than normal rates of ventilation, can cause hypocapnia. You're breathing off too much carbon dioxide, and this can then change your blood levels to be more alkaline, so that leads to respiratory alkalosis. There are two other types of respiration we'll talk about: Cheyne-Stokes respirations and Kussmaul respirations. Cheyne-Stokes respirations can result from really any condition that slows blood flow to the brainstem, which in turn is going to slow impulses that are sending information to the respiratory centers of your brainstem. Neurologic impairment above the brainstem is also a contributor. So somebody that experiences heart failure or stroke could end up with Cheyne-Stokes respiration, depending on the degree or the severity. And the patterns that are identified with Cheyne-Stokes respirations include these alternating periods of apnea, where breathing is extremely shallow or the person is not breathing, and hyperventilation. So that's the opposite ends of the spectrum. So it can almost appear like somebody having very deep and shallow breathing that alternate. Kuzmal respirations are really a deep, labored breathing. And although strenuous exercise can bring it on, so can metabolic acidosis. So if the kidneys are failing to properly regulate the acid-base balance, this can lead to acidosis. And what you'll see in these affected individuals is an increase in their ventilatory rate. They'll have very large tidal volumes. Tidal volume is the volume of air that's breathed in or out during respiration without any expiratory pause. So I'll rephrase it to say that a Kuzmal breathing pattern is an abnormal breathing pattern, and what you'll see is rapid, deep breathing that happens at a consistent pace. Both of these can be a sign of medical emergency. With Kuzmal respiration, those that are diabetic can end up in certain states of metabolic acidosis that can lead to Kuzmal respiration. I'm going to introduce a few lung conditions over the next handful of slides, starting with atelectasis. This is the collapse of lung tissue, and a common mechanism for which alveoli can become atelectic is if there is blockage with mucus. It's what we call a mucus plug, and eventually it can cause the alveoli to collapse and air can no longer inflate that alveoli. Bronchiectasis is persistent abnormal dilation of the bronchi, remembering back to normal anatomy. So what we see with this condition is that there's inflammation of the bronchial wall that leads to destruction of the elastic and muscular components that make up that bronchi, and it causes the wall to weaken and dilate. And so this can happen when an area is chronically inflamed, such as what you would see with smokers. And the primary symptom that you would see here would be this chronic productive cough that can last months or years. Aspiration is the passage of fluid and solid particles into the lung, and it tends to occur more in someone whose normal mechanism of swallowing becomes impaired, along with their cough reflex being impaired. So some predisposing factors could include being in a state where their level of consciousness is altered. So maybe they're sedated. Maybe the person is abusing some sort of substance. The right lung, particularly the right lower lobe, is more susceptible to aspiration because the branching angle of the right main bronchus is straighter than the branching angle of the left bronchus. So taking a closer look at some normal anatomy images will give you a better idea of what I'm talking about. But make sure you're aware that the right lung is more susceptible to aspiration. So aspiration of larger particles, say of food, can lead to an obstruction, whereas aspiration of fluid could lead to pneumonia. In any case, depending on what the fluid is that's been aspirated, it can be very irritating as well to the lungs. Let's say somebody is in an altered state of consciousness. They've maybe abused alcohol, and then they vomit, and they've lost their normal mechanism for being aware of swallowing and their cough reflex because of their current state. And if they're lying on their back, for example, then they can aspirate the vomit that they threw up, which can be quite acidic. Okay, bronchiolitis, itis is inflammation. So this is diffuse inflammation of the small airways, so the bronchioles, and this can lead to bronchoconstriction. So if the bronchioles constrict, then it means less air is able to pass through them. And this is more commonly seen in children, and in adults, it's commonly seen alongside chronic bronchitis. And so just as a reminder, the bronchioles are these smaller branches. Remember, we have the bronchi first, and then we have the bronchioles, which are deeper into the lung. So we're going to look at a couple of chest wall disorders, chest wall restrictions. If the chest wall is deformed, traumatized, immobilized, or even made heavy by fat, the work of breathing is increased and ventilation can be affected because there's a reduction in tidal volume. Remember that volume of air that you would be bringing in and bringing out. And the degree of issues that somebody will experience is going to depend on the severity of that chest wall abnormality. So there is quite a range. Flail chest is a form of chest wall instability that ultimately is a chest wall restriction, and it results from the fracturing of several consecutive ribs, meaning ribs, say you might have maybe rib 5, 6, 7, for example. And they can even fracture in more than one place, or you could have fracture of the sternum and several consecutive ribs. These multiple fractures end up resulting in instability of a portion of the chest wall, causing this paradoxical, almost really meaning just absurd movement of the chest with breathing. And so naturally then chest wall disorders, whatever the cause, are going to contribute to some degree of issues with ventilation, with breathing. This image here is showing you normal inspiration, normal expiration. You can see the ribs end on. And then in this example here, we have the abnormal movement of air due to a chest wall abnormality. On our final slide, we're going to talk about pleural disorders. So let's quickly review the normal anatomy. So the pleura I mentioned earlier are the coverings of the lung, and they are pain sensitive. And we have two pleural coverings. We have the visceral pleura that actually covers the lung themselves, and we can sort of see that if we look closely here at this. This is a transverse cut. So that's the visceral pleura. And then just outside or external to that, we have the parietal pleura. And in between, we have a pleural space where there's a little bit of fluid that would be present. And so the two conditions that we'll talk about that are really the most common type of pleural disorders include a pneumothorax and pleural effusion. A pneumothorax is the presence of air or gas in the pleural space caused by a rupture in either the visceral pleura, the one that surrounds the lung, or the parietal pleura that's just outside of that. As air is drawn into that pleural space, so right here, okay, or right through here, as air is drawn into that pleural space, it separates that visceral and parietal pleura, which destroys the negative pressure of the pleural space. So we normally have a negative pressure found within the pleural space that helps keep the lungs inflated. And then we can have the normal movement of air into and out of our lungs. And so there are different reasons why there could be a rupture. But as an example, if somebody has, let's say, a stab wound or some sort of object that penetrates through the chest wall and pierces through into the lung, it can cause rupturing of the pleura, which causes air to rush in, getting rid of that negative pressure that would normally exist in the pleural space, causing the lung to collapse. Pleural effusion is the presence of fluid within the pleural space, and the source of fluid is usually from blood vessels or lymphatic vessels that are lying near the pleura. Sometimes the fluid, though, can be from an abscess or other lesion that drains into the pleural space. Remember that normally that pleural space should really only have a little bit of fluid. You might recall that it's really about a teaspoon of fluid that's there normally, which really acts as a lubricant, preventing some friction, allowing your lungs to move smoothly in your chest cavity when you breathe. Now, lung disorders, we've talked just briefly about a number of them today, and the clinical manifestations are going to be common to what you would expect if there's a problem with the lungs, and shortness of breath is always a common one. But when it comes to a pleural disorder, such as, let's say, pleural effusion, if there's a little bit of extra fluid, that might not cause any issues. But if there's enough, it's going to cause pain because it's a pain-sensitive structure. Pain in particular when somebody breathes in deep. And that type of pain, what I'd like you to make note of, is called pleuritic pain. So this part of the word here, and then ITIC, pleuritic pain. Okay, so chest pain when breathing in deeply because of that excess fluid within that pleural space. Now, what that fluid is can vary. It can be a watery type of fluid. It can be pus. It could be blood. All, of course, dependent on what the cause of the pleural effusion is. So I hope you enjoyed this introductory lecture to some of the common clinical manifestations and some common lung disorders. And we'll continue on in our next lecture with respiratory disorders. Have a great day. Bye for now.